You walk it out. Oh, you can't take that.
So you gotta give them a damn calorie.
And you pay for the stuff too.
Yeah.
$8 for so.
Brady.
What? She was like, here she goes again.
Renal vasculature. So we're gonna go over some of the anatomy of the kidney, the vasculature, talk about the ultrasound examinations, the indications, why we do them, and then some renal vascular disorders that we might encounter. Next lecture is gonna be talking about renal transplants and allografts. And so just like general information, we know it's a highly vascular organ. So these highly vascular organs have nice low resistant flow patterns. The kidneys receive 20-25% of our total cardiac output. They lie in the retroperitoneal cavity near the posterior body wall, below the level of the diaphragm. The right kidney lies slightly lower than the left due to the presence of the liver being there. So that means that the left kidney typically is a little more superior, a little higher up compared to the right. General measurements in terms of kidney size, they're usually between anywhere from 9 to all the way up to 12 centimeters long, about 5 centimeter wide, 2.5 centimeters thick. When we're measuring kidneys, typically techs and radiologists will look at the length and compare kidney length, not so much the width of the kidney. They're focused more on that length. When we get into the understanding vasculature, that length is very, very important, particularly when we're looking at pediatric patients and looking at the kidneys for peds. Do they measure prone? Do they measure in prone?
Yeah.
Yeah. So
They don't do, width though. I know. Yeah, so like, they don't.
they don't care about width. Yeah, we care about width either.
They do,
The difference between the two kidneys,
yeah, like,
it's 2 centimeters.
2 centimeters.
that's what they
You're
do.
lucky.
I thought it
They
was
they
one,
told me
right?
1 centimeter. Like
Yeah.
we always measure. If it was a 1 centimeter discrepancy in length, go back and recheck
Maybe not for kids, but for adults, they do,
for adults.
right?
I don't know, that's why I asked.
No,
Wait,
I
Nemours is 1, right, or 2?
I can't remember the more, I just.
Might be
I
two.
remember 1. I don't know. Yeah, one.
No, it's
One tech was like to me 1
Hey,
centimeter.
1
but
centimeter.
I'm not sure where I was. I think I was at Nemours.
Yeah, so we'll talk about the reason why is, possibly there was an issue with perfusion, maybe in utero when the baby or fetus was forming, or in the adult population, if you see a major size discrepancy, there might be infarct going on and poor perfusion that's causing that kidney to essentially start to, shrivel or become fibrotic. On the flip side of that, if kidneys enlarged, very large, it could be an issue, maybe thrombosis, we'll see. But we'll talk a little bit more about lengths, what that could mean. So kidneys. The outer portion of that kidney or the parenchyma or the tissue is referred to as the cortex. The inner portion is the medulla. So we have the cortex, surrounding the periphery, the outside of the kidney, that's that outside parenchymal layer, and the central inner portion, that contains the collecting system, the pyramids, is referred to as the medulla. The collecting system where the urine is being formed, so these are what are called pyramids that surround the periphery, that separate, kind of border the cortex and the medulla. Those pyramids have drainage where the urine is being formed in these areas, and it's getting collected and draining towards the hilum or the inner portion of that kidney, or the medial portion of the kidney, where then the ureter connects to that hilum. So everything is kind of flowing in that direction. The urine is being produced and draining out of the kidney and then emptying into the ureter there. That same areas where we have our vessels entering and exiting the kidney, the renal artery and vein. So I'm not gonna go into detail about like, the nephron, moves the paling, and all that stuff. This was A&P. So we're focused more on, the vasculature. So renal arteries and veins. The renal veins are anterior or in front of the renal arteries. So when we're scanning from the anterior approach, the veins are going to be on top of the arteries, so they're going to sit anterior to the arteries. So this was a image on the left, shows the aorta with both the renal arteries branching off. So this is kind of a more coronal approach. There's a little piece of liver up here. You can see the aorta and then our two renal arteries branching off. You can figure out, which is right and which is left based off of the fact that I'm seeing some liver here. We know that the liver is on the patient's right side of their body. So that renal artery is coming off and running towards the liver. So it's running off towards the patient's right side. Whereas this one's going deeper and going off towards the patient's left. So they're probably taking a right coronal approach. So if I'm coming right coronal, that renal artery is coming up towards my transducer. So it's running more, towards my image or towards my transducer, where the other one is going away from me. I'm coming from that right coronal approach. It's going towards the left. The right renal artery arises from the aorta. It's roughly about 2 centimeters below the level of the superior mesenteric artery. We said the arteries are posterior to the veins, their corresponding veins. So the veins anterior, arteries are posterior behind them. Typically they're best visualized when we're in transverse midline. So we find our aorta transverse and we look for the renal arteries branching off the abdominal aorta and transverse. The right renal artery comes off a little more anterolateral. I'll fix that and make it bigger. Circle the fiber makes. So this is IBC. There you go. That right renal artery comes off lateral and a little anterior. So the right one is coming off a little anterolateral. And it's going to go run posterior to the IVC. So you go run behind. The left one is a little more posterolateral, so it's going to come off, somewhere like down in here. Run out towards left kidney. So that's kind of like the presentation. So just for anatomy, so it runs again posterior to the IVC. It's longer than the left renal artery because again it's got to cross midline, get all the way out to the right kidney. That's sitting somewhere out here. It's got a longer distance to go. Whereas your left kidney, can be sitting somewhere over here. It's just much shorter in distance. Both abdomen and vascular boards loves to show a picture of the IVC and then that anechoic structure sitting posterior behind the IVC to represent the right renal artery. So pretty much every student has told me, yep, that's on there. I've always asked them. So they'll show you a picture with the liver, the IVC coursing, posterior behind the liver. And then they'll either ask you, place the star or the marker on the right renal artery. So there'll be other vasculature in there, and they want you to kind of just figure out where that right renal artery is. Sometimes they can get a little tricky on you, and they'll put 2 little anechoic circles there, and that'll represent an anatomical variant of a duplicated right renal artery, and they want you to recognize that. So I've seen that too. They try to get a little tricky on you. Like, what pathology is shown in this image? And you're looking at it and going, or what anatomical variant is seen in this image, you know? It's not really a pathology, or what anatomical variant is seen in this image, and they want you to recognize the duplicated right renal artery. So left renal artery, lateral or posterolateral. So then it comes off lateral, loma posterolateral. Shorter in length compared to the right. It's posterior to the body of the pancreas and the splenic vein as well. So we can see just kind of that representation, that right renal artery coursing behind, posterior to the IVC. Nice breakdown. So when we're looking at our renal vessels, left renal artery, right renal artery going posterior to the IVC. We also have the renal veins now. So right renal vein and left renal vein. And then we'll see in a moment when we talk about renal veins, what's unique about the left renal vein is that it courses in between our SMA, our superior mesenteric artery, and our aorta. So it's anterior in front of the aorta, but posterior to the SMA. Yep. This is that again, that transverse midline. So we're kind of in that same level, you know, where the pancreas kind of is as well. You know, the boards loves to have you recognize and understand, you know, this whole orientation of the vessels here. So transverse, aorta, IVC, or SMA, superior mesenteric artery, and then your right and left renal arteries. Right renal artery coursing behind, posterior to the IVC. Left renal vein coursing in between SMA and aorta. That's what it looks like now sonographically. I'm just kind of get your bearings. You see, same thing. Right renal artery, core running behind the IVC. Like we said, posterior behind the renal vein, the corresponding renal vein running out towards the right kidney. And on the left side, again, we see the left renal vein as it's draining into the IVC and running in between or sandwiched in between our aorta and superior mesenteric artery. Again, the arteries are posterior to the veins for orientation. When we get into finally imaging the renal arteries, we're going to try to see if we can visualize them, you know, in that transverse midline view. If not visualized that way, we'll try decubing the patient and taking a coronal approach. So this is something I refer to as a banana peel sign. With that coronal approach, you can see the abdominal aorta and you get a good visualization of the origins of the right and left renal arteries. And from this approach, you can get pretty good Doppler angles on those vessels as well to get accurate velocity measurements, where sometimes it can be pretty challenging with it in transverse. So, you know, that Doppler angle is going to be pretty close to 90 degrees, and it's going to be hard to get a good Doppler angle. Left's a little bit better, but that right one is real challenging coming off there. Versus, you know, doing a nice banana peel, you can just almost zero angle it, and you're lined up perfect. So again, just, you know, eventually just get yourself more and more comfortable looking at these ultrasound pictures. You know, now we see that IVC. So with that picture, you know, that shows the right renal artery, the IVC, you know, isn't going to be nice and straight like the aorta is. You know, the aorta is nice and uniform. You know, you don't see any bending, twisting, any areas that are dilated or narrow. So you can recognize the IVC with that. Aorta, you'll also see, you know, the luminal walls, the aortic walls, arterial walls. Again, you see some liver present, the IVC, and then the right renal artery.
Hey Dan, in that image, what is that the kidney that anechoic structure there that the right renal artery is running towards?
I feel like that's probably gallbladder with some little stones in there.
Okay,
Yeah, kidney is gonna be.
gotcha. It'd be farther up.
Yeah, it's gotta be further out, yeah.
What's that branching to it then? Is that like a dilator? Bile duct? Is it stones?
Probably not. I don't know, I mean, we're sagittal coronal, so. I'm not sure what we're clipping there, but
Okay,
yeah, it's definitely all
that's
on
right,
it.
alright.
So this is that banana peel view. Got our color image. So we're coming again from that coronal approach, trying to image the origin of the right renal artery, the left renal artery. We can get a nice, image of the vessels there. And we're optimized because we're close to that 0 angle, so our velocity is gonna be very true. It's a good link if you wanna see a woman here who, demonstrates, imaging that. So in terms of normal renal arteries and veins, kidneys should have nice low resistant flow patterns, so monophasic, everything above the baseline. They should have a nice fast upstroke, so a fast systolic rise. And then that gradual diastolic runoff. So it should look similar, to like a carotid artery waveform, an ICA. Should look similar to, things like testicular ovarian flow. So it should be nice, low resistant. RIs should be, in that 0.6 range, 0.5, 0.6, 0.7 at the high end. With the renal veins, there is some pulsatility to it, so some slight pulsatility, some slight respiratory variations to it. And then depending on the patient, you can sometimes get nice pictures showing the entirety of the vessel. It's going to become important, for us to be able to visualize the entirety of the vessel to make the definitive diagnoses of, renal artery stenosis. Those who've seen these done can attest that oftentimes they're very limited. They oftentimes don't see the origins of the renal arteries, and they can only get a small segment closer towards the highland of the kidney. Maybe they'll get a distal, a little bit of mid, and that's all they got. So in those cases, we just have to go based off our waveforms, what that's telling us, if there is a potential significant stenosis more proximal. Left kidney thighs too. So depending on, patient's body habitus, we can come from the left side and come a little more coronal, and we could see that aorta coursing across, and we can get that left renal artery coming right off the aorta, going right up to the kidney. So that's a kind of a nice view from the left side. So sometimes lefts can be a little bit easier, or is easier, imaging than the right. So branching patterns. So you guys have to memorize your branching patterns now for the renal arteries. So it starts with the main renal artery coming off, the aorta. We have a right and left main renal artery. The first branch of the main renal artery are going to be the segmental arteries. Segmental arteries branch into anterior posterior division. The segmental arteries then further split into the interlobar arteries. Interlobar arteries then, of course, you get a picture. Oh. There you go. So, main renal artery branching into your segmental arteries. The segmental arteries then branch further into your interlobar arteries. So these are the vessels that are running in between the lobes or the poles of the kidney. So superior, mid, lower pole. Those are their interlobars. Those interlobars continue, and they then wrap around the pyramids. And when they do that wrap around the pyramids, they become the arcuate arteries. So it's interlobar, coursing along the pyramids, and then it does like this kind of like a 90-degree turn. And when it does that small turn, and it's at the top or at the base of the pyramid, so we refer to it as the base of the pyramid. So here's the base coming to the point of the pyramid. Along the base of the pyramid is where we have our arcuate arteries. So main renal, segmental, interlobar, arcuate. And then the small little projections off the arcuate that go out into the periphery of the cortex are interlobular. So a lot of students mix up interlobular and interlobar. So the lobular, the small little like thin, arteries or projections that go out into the cortex. So you can see a little bit better here. So the arcuate are the ones that, wrap around the pyramids there. And then the small little hair-like ones that perfuse the cortex are the interlobular. I did it. Interlobular. The main segmentals, interlobar, arcuate, and then interlobular. So some patients might present with duplicated renal arteries. So multiple main renal arteries might enter the renal hilum and supply the segmental arteries. This can cause patients to potentially present with hypertension, renal insufficiency. This might be a little more common in patients who have what's referred to as a duplicated system or duplicated kidney, where they actually have two ureters exiting the kidney, and then the kidney is almost operating as like two, even though they're connected, they're operating kind of like almost like two independent kidneys that have almost been like fused together. So the upper pole might have its own dedicated supply, the lower pole might have its own dedicated blood supply and venous drainage. So again, duplicated systems and duplicated vessels do exist. So you just have to be like kind of aware and cognizant of it. It's not that common, but potentially could exist. We're seeing that duplicated right renal artery, that classic picture. Posterior to the IVC, two anechoic structures there. And then here with in our frontal approach, see this patient has two left renal arteries now. So our CT. And typically when they do have this duplicated renal arteries, there's one supplying the upper pole, one supplying that lower pole. So venous anatomy. We said the veins are anterior or in front of the renal arteries. The right renal vein is shorter in length than the left compared to the left. They extend directly into the IVC. The left renal vein has a couple things that are unique to it. So first and foremost, just remember it passes anterior to the aorta, in front of the aorta, and posterior to the IVC. So it's sandwiched in between those two vessels. But with the left renal vein, it has some tributaries that are draining into it. So we have the left adrenal vein, as well as the left gonadal vein. So if it's a male, it's the left testicular vein. If it's a female, it's the left ovarian vein. Both drain into the left renal vein, and then that subsequently drains into the IVC. In terms of branching patterns, nice, we just kind of reverse the process for the renal arteries. So we start with those interlobular in the periphery and the cortex of the kidney, and we work our way in reverse, interlobular to arcuate veins, to interlobar veins, to the segmental veins, to the main renal vein. In terms of anatomic variants, the most common is going to be something I'm referred to as a circumaortic left renal vein. So meaning that the left renal vein exits the kidney and then splits, and actually one branch of that vessel goes anterior to the kidney, another branch of it goes posterior to the kidney, so it kind of hugs it, and then most of the times they come back together a little further distal once they get past the aorta. And so renal veins, we just take that branching pattern, just go in reverse. Start with your interlobular out in the periphery of the cortex of the kidney. Then the arcuate veins. Then the interlobar veins. Together, the lobes, they come together, form the segmental veins, and then the main renal vein. Got a nice beautiful right renal vein there. Draining right into the IVC. Nice clear picture. Then our left renal vein, coursing between our aorta and SMA. There's that circumaortic left renal vein. So it kind of splits. So in this case, they're showing, the two distinct veins draining into the IVC. I've seen them come back together, converge, and then drain into the IVC. With this circumaortic left renal vein, the issues with this is we can sometimes get compression of the portion that's posterior to the aorta, between the aorta and the spine. So we can wind up with some compression there that could lead to potential thrombosis or reduced venous drainage. Some patients might have a retroaortic left renal vein, so the entire left renal vein is just posterior to the aorta. So again, this condition, we can sometimes wind up with compression of that left renal vein between the aorta now and the patient's spine. That epidemic here is the patient's spine. Just kind of see how posterior everything is. I don't know why they said that's a variation, but 80 to 90% of patients are like anatomical variations, or it's not anatomical variation. 80-95% of patients, their aorta or their left renal vein is pre-aortic or in front of the aorta. 7 to 9 have circumaortic left renal vein. And then about 2 to 3% of the population have a retroaortic left renal vein.
What is circumaortic?
That's the one that goes one in front
Oh,
and one
and one
right.
behind,
So it's kind of going around. All right, so nutcracker syndrome. So the DMS students are very familiar with nutcracker syndrome. They always talk about it. This is compression of the left renal vein between the SMA and the aorta. So because it's coursing in between those two vessels, we can sometimes wind up with compression of the vein by those, or in between those two vessels. And when we get compression of that vein, that could lead to stenosis. It could lead to stasis of blood. It can potentially lead to thrombosis of the left renal vein. So we can make the diagnosis if we see fast turbulent flow through that area where we get a stenotic lesion. It could affect the kidney as well. And these patients can wind up with kidney issues, including flank pain, blood in the urine, hematuria. So again, we just use our color Doppler to kind of help guide us. So when we put color on, we see aliasine representing turbulent flow in that area of narrowing. On 2D, so here we see that area of narrowing, and then proximal to it, we get some dilatation of that left renal vein. So it kind of just makes sense. Blood flow is draining out of the kidney. It's trying to make its way back to the IVC. It's being compressed right now, so all that blood flow is just kind of building up on the other side of that stricture or that narrowing. With color Doppler, so they were measuring velocities. So they measure 320 centimeters per second, so, you know, we know that that's exceedingly fast when we're talking about, the venous system. So again, because of that narrowing, that dilatation, that stasis of blood, that's going on there, we worry about this potentially becoming thrombosed at some point. So that's nutcracker syndrome. When we want to assess vasculature for the kidney, angiogram is the gold standard. So if either doing, you know, digital subtraction angiography. We can also utilize our CTA or MRA to also assess for renal vascular disease. So with that CTA or MRA, we also get, you know, nice pictures of the kidney tissue as well. So it can be useful in that sense, as opposed to just an angiogram that only focuses on the vessels. But the thing to consider is, you know, these exams, both angiogram and CTA, require the use of contrast. We're looking at the kidneys. There's a reason why we're looking at the kidneys, probably because they have kidney disease. So oftentimes, you know, they're not candidates for this because we could further damage the kidneys because those contrast agents are nephrotoxic. So they may not be, you know, candidates for that. So we have to go to the ultrasound. Unfortunately, you know, sometimes it's very difficult to scan, takes a good deal of technical, you know, ability. So may need ultrasound contrast agents to better assess these. So thankfully, our contrast agents, you know, are safe. You know, they're not nephrotoxic. It's essentially just, you know, gas bubbles that we utilize that helps to better visualize the vasculature, help to visualize the renal arteries, you know, in their entirety. We'll talk a little bit later in the semester about some of the contrast agents we use. So we want to rule out renal artery stenosis when we're doing a renal artery Doppler. We can also investigate, you know, tumor vascularity or extension. So we haven't mentioned it yet. We talked a little bit briefly about, like, there are certain types of cancers that like to grow into the vessels. So namely, you know, hepatocellular carcinoma and renal cellular carcinoma. Those are the two cancers that like to grow into the vasculature. So we could look for tumor invasion into our renal veins. We can differentiate between things like hydronephrosis versus vessels. Use it to evaluate renal transplants. When we're doing a renal artery Doppler, we typically want the patient's NPO. That'll help eliminate some of the overlying bile gas. So NPO helps. Utilize multiple positions: supine, lateral, decubitus, oblique, even prone. Then use our curved our curved array transducer. So lower frequency 2 to 5. Use a small sample volume gate when we're Dopplering these vessels because they are very small, and make sure our Doppler angles, you know, are less than 60 degrees. So indications. So again, those of you in DMS, you want to make sure that you're doing the proper exam and you have the good proper indications for renal artery Doppler. So we look for things like hypertension. That's the main thing. So when we have patients that have uncontrolled hypertension, particularly hypertension in a young patient, you know, we don't expect, you know, like a 20 or 30-year-old to have, you know, severe hypertension. Patients that have rapidly accelerating hypertension, you know, something might be going on in that case. All of a sudden their pressures just start spiking. They're not responsive to medications. So patients with hypertension that's difficult to control. Patients who have high blood pressure and then deteriorating renal function. So we're looking at their BUN, their creatinine levels. They're starting to spike and continue to go up. Or if we see a size discrepancy in the kidneys. So if we're doing a normal renal exam and we see a big discrepancy between the right and left kidneys, that warrants, you know, us doing a renal artery Doppler exam to see why there is that size discrepancy. Is it vascular related? So in terms of high blood pressure, hypertension. So primary hypertension, is what we see in the majority of patients. So that's just, you have high blood pressure. There isn't an underlying cause to that blood pressure. And most patients, it's just idiopathic, or we're not sure why they develop high blood pressure. There are risk factors that can contribute to it: stress, obesity, salt sensitivity. There's a definite genetic factor or genetic component to it. Even potassium deficiency, vitamin D deficiency. And then secondary hypertension results from an identifiable cause. So we know why that patient, has hypertension, and it's something that's directly causing, it's a direct cause of that hypertension. So Cushing syndrome. Cushing syndrome is either a tumor on the patient's adrenal gland, or a tumor potentially in the pituitary gland, that's impacting the adrenals, and then leading to hypertension. Thyroid issues, so hyper and hypothyroidism could lead to hypertension. Phenochromocystoma, illicit drug use, could cause hypertension, so certain stimulants. And then renal artery stenosis. So renal artery stenosis is the most common curable cause, so we can, absolutely do something about that. That's the primary cause for secondary hypertension. Yeah, I'm not gonna go over get into the renin-angiotensin system. Don't worry about these guys. Thank you. Yeah. Just jump right into our protocol. So when we're doing a renal artery Doppler, it all starts with the aorta. So we got to get a nice sagittal aorta picture. We want to Doppler the aorta around the level of the renal arteries. So we're Dopplering mid-aorta, looking at the aorta. It's important because, if they have atherosclerosis in the aorta, those velocities are going to be elevated, and that's going to impact the renal arteries. If they have a AAA and they're aneurysmal, that blood flow, the velocities are going to be severely diminished, and that's going to also impact the velocities that we get in our renal arteries, and affect perfusion through the renal arteries. So we have to get a baseline velocity for our abdominal aorta. That baseline velocity is important because there's a certain ratio that we calculate called an RAR, a renal artery to aortic ratio. And there's a certain threshold or number that we look at to determine yes or no, is there renal artery stenosis. The renal arteries, we want to image them from the origin all the way out to the hilum of the kidney. So particularly important is the origin. That's where, again, the majority of our stenoses are going to occur when we're talking about atherosclerosis and renal artery stenosis. We see it at the origins, the proximal portions of the renal arteries. We're going to know, velocities, evaluate the Doppler waveforms. Follow, again, the renal arteries all the way out. And then we're going to look at the kidneys now. We're going to assess the length of the kidney. Look at the echo texture of the kidney. Is it echogenic? Is it bright? Is it homogeneous? We look at the thickness of the parenchyma, so the cortex of that kidney, because that's a good indicator of if there is, potential parenchymal disease. So kidneys that are, diseased and they're starving for blood, that cortex starts to become thinner and thinner and thinner. The kidneys also start to atrophy. They become scarred. We can look for things like cysts, stones, calculi, hydronephrosis. Any idea? Have you ever heard hydronephrosis, you guys?
I was like, what?
No.
Have you ever heard of hydronephrosis?
The CVS students.
What
So
is
hydronephrosis,
that?
what is hydronephrosis? Tell us. So that's the block, the buildup of urine within the ureters and the collecting system of the kidney. So it's due to an obstruction of the flow of urine, and the urine backs up to the kidney. So we look for the presence of hydronephrosis. Any renal masses, tumors, masses, lesions. So we're also assessing, the renal parenchyma as we're doing a renal artery Doppler. We evaluate then the intrarenal vasculature, so we look at the vessels. So it depends on, you know, your labs protocol and, where you're working. So in here it says segmental and interior lobar. Christiana does arcuate. We would do segmental and arcuate back in New York, so we do right near, where it first starts to branch, and then we go further out into the arcuate. Good rule of thumb is like, you know, Doppler out towards the cortex, like out in the periphery, because that's where the flow is first going to start to be diminished. That's where you're first going to start losing your flow. So once you start doing a good number of renal artery Doppler exams or enough kidney exams, you'll notice when patients have parenchymal disease or kidney disease, they start losing flow in the cortex, and you just see flow kind of in the center of that kidney, you know, in the collecting systems, and very poor perfusion all the way out to the borders or out to the edges of the kidney. We'll evaluate the intrarenals. We'll look at upper pole, mid pole, lower pole, the intrarenals at the 3 levels of the kidney. When we get into the protocol. To make the diagnosis of renal artery stenosis, we can have a direct method or an indirect method. With the direct method, we have to be able to visualize the entirety of that main renal artery as it courses all the way from the origin out to the hilum of the kidney. The indirect method is when we don't visualize, you know, the origin of it or the entirety of that vessel, and we can only see, you know, the renal artery near the hilum, so we only get a distal or a mid-distal portion of it. And then we Doppler the intrarenal vessels, and we use our information from that to kind of surmise and infer that this patient has renal artery stenosis. So if we're using that indirect method, what do you guys think the waveforms would look like? What are we gonna see? Our magic word for post-stenotic.
Oh, we'll see like
TARDIS waveforms, yes. So indirect method, we're looking for post-stenotic TARDIS waveforms. So when we don't see the entire renal artery, we go out to the kidney, we can see the kidneys, we're Dopplering in the kidney. You know, you see TARDIS waveforms. We know that we can infer that there's a significant stenotic lesion proximal that they have to go get a CT or some additional imaging, an MR if they can't do contrast, you know. So we can infer, or that's an indirect method to make that diagnosis. That's kind of what that's summarizing. Yeah. Direct method, we need to visualize the entirety of it. All right, interpretation. So direct method, we're going to calculate our RAR, our renal artery to aortic ratio. RAR. So if it helps you, put a little like, you know, division sign in between the first R and the A, the RA. So you know what's in the numerator, the renal artery is in the numerator, the aorta is in the denominator. And it's the ratio of that we're looking at, renal artery to aortic ratio. That's terrible for me because I'm dyslexic. I don't know why it's freaking up every time I look at that. So with that RAR, we do the highest renal artery piece of stock velocity divided by that aortic velocity that we got at that mid segment. So that's why so it all starts with that aortic image. That's going to be our critical, and that's going to be our denominator. So what we're looking for, if that RAR is less than 3.5, it's considered normal. If the RAR is greater than 3.5, then it equates to a 60% diameter reduction. So we have a hemodynamically significant lesion in that case. So 3.5 is your magic number. That's the one we have to remember. Less than 3.5, normal. Greater than 3.5, abnormal. Or 3.5 or greater, abnormal. In terms of velocities now. We could utilize a pizza stock velocity, it's 180, is the one that, the boards uses, and pretty sure Christiane uses 180 as well. The greater than 180, again, equates to a greater than 60% diameter reduction. And then less than 180 is considered normal for our renal arteries. Again, the RAR is, more sensitive because it takes into account, the effects of the aortic velocity in that case. Like we said, if someone's got an aneurysm, those aortic velocities are going to be very low. And then, these could potentially be very high and kind of skew our ratio or a comparison, and it will potentially, skew the ratio a little bit. Or I'm not, it won't skew the ratio, but like if the aortic velocities are low, these are also going to be low as well, but the ratio could still be high and be stenotic. And it won't, get to that 180 criteria. So I'm just kind of like throwing some numbers in there, like if this is like the aorta is like 20 and the renal artery is 120, that would be 4. No, it'd be more, it'd be 6, right? 6. But 120 wouldn't fall under that criteria. And then on the flip side of that, if the aorta is very fast, like 200, and this is 300, we have a ratio that's under that 3.5. So, again, that ratio, is important because it's more sensitive to aortic changes, or it takes into account for changes in the aortic velocity. So our normal Doppler waveforms should be nice, low resistant waveforms. Show nice diastolic flow pattern, so fast uprise, nice diastolic flow pattern. So typical ranges, around 100. Then depends on the age of the patient. The origins are a little more turbulent, so there's more spectral broadening and filling in because it is the origin of it, so we don't have that nice laminar flow at that point. And then it becomes more laminar as you work your way closer towards the kidney. Just looking at degree of stenosis. To be honest, when you're reporting out, they really only report out, greater than 60%. If your RAR is greater than, 3.5, your piece of solid velocity greater than 180. The resistive indices. Again, just kind of refresher, calculating your RIs, your resistive indices. You're going to be measuring this every single time. So peak systolic and end diastolic velocities are, critical to doing a renal artery Doppler. RIs are our first, real indicator that there is the presence or an issue going on in the kidneys. So we can use them as a very useful diagnostic tool to the doctor to determine, if there is something going on. So normally they should be less than 0.7. Greater than 0.8 is considered very high resistance and considered abnormal. We're going to learn about some of the different conditions that could lead to, elevated RIs, but this is just kind of just going into a couple of them. So the conditions are quite numerous. So everything from parenchymal renal disease to a condition called acute tubular necrosis we're going to learn about, to renal vein thrombosis, to even urinary tract obstruction. So hydronephrosis, can raise a patient's RIs. So a couple of things that we also look for are early systolic peak and targus parvus waveforms. So in this early systolic peak, in the initial, acceleration phase, we could see an absence of that, EPS, that early systolic peak, and that's usually a predictor of a significant, renal artery stenosis. So we'll notice when you're doing that renal arteries, you'll get this sharp peak, or it's gonna rise up a bit of, and then you kind of get this little secondary peak. But if you don't have that nice, little peak up there, that could indicate potential, renal arteries. I'm sorry. That makes sense. No, that's the second push. There's stenosis. No, that's wrong. Let's fix this. No, that is right. Why is this normal? These got to be flipped. Hold on. Yeah, that's got to be flipped. That's an error. So like when we have a stenosis that's blocking it, the heart during its first initial contraction gives us a nice quick spike or peak of blood. If there's a blockage, we're gonna lose that little spike there, and it's gonna be very similar and very even. So the second push of that blood, like with the full contraction of the heart, as it's pushing through, so you got initial surge, and then as the heart continues to contract with the pulse, you get a second push, and you wind up with two peaks. So a lot of renal artery waveforms, you're going to notice those two peaks. If they're pretty similar in nature, that could indicate the presence of a stenosis. That first peak should be higher. And then tardish parvus waveforms. So recognizing tardish parvus waveforms downstream to stenosis. So that's absolutely critical, when we're looking for renal artery stenosis. Fix that. Some labs will do a end diastolic ratio, looking at the end diastolic velocities. Personally, I've never seen this done in any of the labs. But we can compare that end diastolic velocity divided by the peak systolic velocity to look at this end diastolic velocity ratio. So if that ratio is less than 0.2, this can indicate being abnormal. Something that labs do that we did quite frequently is look at the acceleration times or the acceleration indexes for the blood flow, particularly intrarenal, when we're assessing the intrarenal vasculature within the kidney. And absolutely with transplants, we would always measure our acceleration index and our rise time. So we calculate acceleration index or rise time. Has anyone ever tried doing this? Like playing around with acceleration index or rise time? So basically you just obtain your Doppler tracing and you collect the function on the machine. We want to measure acceleration time or acceleration index. And you just put your caliper at the start of systole and you trace and you put your other caliper along but the peak systolic velocity, and you kind of just tracing along the slope of that curve as during that acceleration rise time. And then the machine calculates the time it took to get to peak systolic velocity, and it's also measuring the slope of that curve. So we want very quick or very short acceleration times. So that time should be very short to go from the start of systole up to that peak systolic velocity. If we have a prolonged acceleration time greater than 0.07 seconds, that indicates renal artery stenosis. So we're looking for prolonged acceleration times. They can use that, again, the speed and the slope of that rise compared to the time to create an index as well. The index for that is gonna be, greater than, I'm sorry, less than, yeah, acceleration time is, less than, 300 centimeters per second. Then this indicates, per second squared, sorry, indicates a greater than, 60% stenosis. No, less than, sorry. So long acceleration times and then shorter, acceleration index. Limitations. A lot of it has to do with patient's body habitus, imaging characteristics, overlying bowel gas. Patient respiration plays a big part of it. So patients who are short of breath have rapid respirations. Their kidneys are shifting up and down, with that diaphragm going up and down. Patients who are non-fasting might have a lot of overlying bowel gas. We might not identify if they have, multiple renal arteries. They might not be readily apparent or identifiable. So sometimes we can have false negatives. So in this case, they saw elevated velocities in the left renal artery consistent with a significant stenosis. In this case, the hilar waveform obtained from the left kidney is normal in appearance. And this gives false negative appearance based off of the indirect arterial sampling. In this case, they actually had, a significant lesion, but those intrarenals, they demonstrated a normal looking intrarenal vessel. All right, so vascular disorders, let's go over stenosis, aneurysm, some non-vascular causes of renal disease, renal vein thrombosis, the tumor extension, and then some additional pathologies. So stenosis or occlusion of the renal artery can cause ischemia. So we get diminished blood supply going to the kidneys. This leads to hypertension developing in the kidneys or renal insufficiency. So when we talk about reduced perfusion, we refer to that as being, insufficiency. There's diminished blood flow getting to the kidneys. We said that renal artery stenosis is the most common correctable cause of hypertension. So we can do something about it. We can go in there, stent open the vessel, and then reperfuse the kidney. Risk factors, most common cause of renal artery stenosis is going to be the development of atherosclerotic plaques in the main renal arteries. And it's typically at the origin or near the origin of the main renal arteries. So again, atherosclerosis is a slow process, takes years to develop. So we would expect to see this in older patient populations. If we have, again, a younger patient now, particularly a female, and they have uncontrollable hypertension, they're constantly on hypertension, they're not responding to medications. We then worry about FMD, fibromuscular dysplasia. So FMD is an arterial disease that affects primarily young to middle-aged women, and it affects the medium to large arteries in our body. So in this case, it's the renal arteries that are affected. It's the internal carotid arteries, in terms of the carotid vasculature, we'd see it maybe in the internal carotid arteries. FMD causes the vessel to have what's referred to as that string of pearl or string of beads. So anytime you see any boards questions or anything referring to, string of pearls, string of bead appearance. So automatically FFD, young, females. So this could be a primary cause of, renal artery stenosis. Other additional causes could be trauma to the vessels, arteritis, or aneurysm of the vessel. The other thing about FMD is the location of it too. So it's going to affect the distal 2/3 of that main renal artery. So the proximal portion is okay. And then that string of beads appearance will occur, distally as we get more closer towards the kidney or further out. So you can kind of use that, to help make the differentiation between the two as well. If it's stenotic near the origin, it's going to be atherosclerosis. If the issue is, further out, mid-distal segment of the main renal artery, it's going to be FMD. So again, we don't typically see stenotic lesions, out by the hilum. So again, our angiography is the more definitive test when we want to look for stenosis. It's our gold standard. We look for increased velocities in that stenotic area, post-stenotic turbulence, and then that targus parvus waveform. We used to look for that absence of that early systolic peak, prolonged acceleration times. So again, that prolonged acceleration time goes hand in hand with that targus parvus waveform. On ultrasound, we can look at the kidney parenchyma, the tissue, looking for, changes in the renal parenchyma. If the kidney start to become, fibrotic, and become heterogeneous, is it atrophic? Is it reduced in size? We look for the kidney for potential causes as well, of stenosis. We assess the branches, the intrarenal arteries, again, looking for any issues or problems, assessing the Doppler waveforms, looking for, that post-stenotic targus parvus waveforms, intrarenal. With those high-grade stenosis, again, RAR is over 3.5, velocities greater than 180, prolonged acceleration times greater than 0.07, and acceleration index less than on 300 centimeters per second squared. Just an example of a report, workup or worksheet. You have your aorta velocity, your renal artery velocities, then your highest renal artery velocities in each side, and then your calculation for your RARs. Nice thing now, the machine will spit out all these numbers for you. Put in a nice worksheet. And then the intrarenal vessels. So when we're near the origin, we're going to look for color aliasing, that potentially indicate a stenosis. That's a lot of color bleed going on there. Yeah. So in this patient, they demonstrated aliasing near the origin with a velocity over 380. The aortic velocity was only 89 with this significant RAR. And then when they were intrarenal, in this case, they were doppling the segmental arteries within the kidney. There's an obvious targus parvus waveform. So we have that delayed upstroke, reduced velocity, but it's still low resistant, low velocity, delayed upstroke. So we have a prolonged acceleration time. So that AT is going to be prolonged greater than 0.07. Here they have very fast velocity, elevated velocity at the origin. And then significantly tardious parvis, with significant tardious parvis waveforms. In the upper segment of, or the upper pole of the intrarenal vessels. See just kind of how rounded it is. And following a stent placement, so that same patient, they placed a stent now in the left renal artery, so we got a nice healthier looking, velocity measurement within normal range. And definite improvement of our intrarenal vasculature, so that rise time, is significantly better than the previous study. So we got much improved acceleration time, a healthier looking intrarenal waveform. So this was a nice image kind of showing the difference in intimal thickness. So in this case, it's the right renal artery that's stenotic. In the right kidney, it only measured about 10.1 centimeters. Left kidney was almost 12 centimeters. The cortical thickness, so you can see the cortex, the hypoechoic darker cortex surrounding the kidney, is much thicker on the left one than compared to the right one. So we have cortical thickening or thinning going on in the disease side. So again, as this disease progresses and gets worse, that cortex becomes thinner and thinner and thinner. So we can compare the cortex size, the size of the kidney. So the right one is starving for blood, whereas the left one has normal perfusion. So here we can see very, high resistant Doppler waveforms. And parvis when we're intrarenal. So acceleration time is 0.17. So that's significantly higher than a 0.07, which is our cutoff, our normal. Showing the intrarenal acceleration times. Here they put the caliper beginning with peak systolic, measure up along the slope to peak systolic velocity. Acceleration time here, 0.07. So falls just within that normal range, and then a prolonged acceleration time. So for you guys, when you do, eventually sit for your bachelor boards, which you are, I'm going to force all of you. Even if you have no idea, I can't remember, oh God, what are the acceleration times normal? They're going to give you two acceleration times potentially. The one that's longer is the one that has disease. So no matter whatever you're imaging in the body, no matter what it is, if they provide you two different acceleration times, one is very quick, a short number, small number, and one's a larger number. The larger number is the disease side. And they're trying to make you make that correlation to post-stenotic tardious parvis waveform. They want you to recognize, all right, it's a tardious parvis waveform because it has a long acceleration time. So then from there, you can pick whatever vessel is proximal to it. If they say this Doppler waveform or these measurements came from the distal right renal artery and the distal left renal artery, and they're giving you two acceleration times. The right one is much longer. Where is the disease? Don't pick in the kidney, because that's wrong. It's going to be proximal to wherever that sample site is. They want you to recognize that's a post-stenotic tardious parvis waveform with a prolonged acceleration time. So even if you know nothing, remember the numbers are, just pick the one with the longer acceleration time is the side with the disease. That's where the disease is, if they're giving you comparing two of them. What's the pathology we see in this picture? Yeah. Renal artery stenosis. You can see it right there, right near the origin. So again, Yeah, cortices in the renal artery. There you go.
That's actually part.
What?
That's fine.
What?
But they won't go like one. Yeah, go like this.
Oh, you're saying that's the spine?
Like,
Funny. Yeah, what's going on down here with their spine then?
Yeah.
Okay.
oh, the one that guided?
Yeah, the
why?
line.
Why?
A spinal
Good. My
plexus.
spleen,
Yeah.
Yeah. Skeletal dysplasia, right? They have a lot going on.
Actually, it's not spinal.
I don't think that's right.
Spinal, that's actually,
It's spike.
it's bifurcated.
Gets into the femur.
That's a femur?
Yeah. That's the start.
We're all like slightly losing our mind.
I see.
We're 2/3 of the way, we're almost done, actually. FMD, fibromuscular dysplasia. So again, think young female patients with uncontrolled hypertension. We're gonna then potentially do a renal artery Doppler to see if they have fibromuscular dysplasia. Because the renal arteries are commonly affected. Other places we could potentially look to make that diagnosis, we could look at the carotid arteries. So particularly the internal carotid arteries, so when we're imaging the carotids, we look at the ICAs. Not so much the CCA, because that's actually a little too large. CCA, we're probably more worried about Takayasu's arteritis. That's the one that we would affect the proximal CCAs. So FMD, then carotid arteries, maybe lumbar arteries, celiac artery, hepatic arteries, so some of those little smaller branch vessels off the aorta. Etiology of FMD is unknown, so we're not really sure like why these women develop it. And then the treatment for it is we can actually go in and do angioplasty, so we can balloon angioplasty those segments that are narrowed. And then potentially place stents to keep them open. So this is an effective treatment for, women who are suffering or patients who are suffering from FMD. Truth be told, making the diagnosis on the ultrasound's hard, really hard. These vessels are super duper small. When you put your color on, you get a lot of color bleed sometimes. You really have to crank up your color Doppler when you're doing a renal artery Doppler to get any sort of flow in the vessel. So sometimes you wind up with a lot of bleeding, so it can become challenging to see, really on ultrasound. But again, you kind of use your logic here, if it's, atherosclerosis, it's gonna be near that origin. When we get into the distal 2/3 and we're getting, areas of turbulent flow, elevated velocities as we're Dopplering through here, we fits the bill. The patient population's right, it's a young female. The distal 2/3 is where we're seeing that those elevated velocities. All right, it's starting to make sense, even if we don't see that, a telltale string of pearls that we see. So yeah, angio, it's much more readily apparent where we see it. With it, they also take a corkscrew appearance as well, so the vessel would become very tortuous and almost take like a corkscrew appearance. There's MRI demonstrating the string of beads appearance that we see with FMD. Artery. That's not me. This one up here is this stomach artery.
Wow.
When they say it's tortuous. They weren't kidding. So it looks like celiac is coming off right here and then the stomach artery is like going that way. Alright, so renal artery occlusion. So absence of a visible main renal artery, we can make that diagnosis if we, we don't visualize or there's absence of that main renal artery. If we see a very markedly reduced kidney size, the kidney that's teeny tiny, less than 9 centimeters. We're imaging the kidney and we put our color on, and there's absence of arterial flow in the kidney, bad sign. can make kind of make that diagnosis of occluded renal artery. Or we have very dampened, intrarenal flow, so it's almost non-existent. So if that renal artery occlusion is bilateral, patient's going to wind up in renal failure, not a good thing. Renal artery occlusion could lead to focal renal infarct as well. So, if the patient has an occluded renal artery, we're able to reperfuse and get blood flow back into that kidney. It could lead to those areas of focal infarct. It's a little hard to see. Transverse color flow image demonstrates absence of flow in the expected location of the right renal artery. So we're transverse, we have our aorta, we expect to see that right renal artery coming off. Don't see it. So angiogram kind of confirmed occlusion of the occlusion of that. Again, if you don't see the renal artery, and then you move out to the kidney now, and you're imaging your kidney. You're the right kidney, measured 11.5 centimeters. We put our color on, we still see some flow. This patient probably has disease on both sides because again, we're not seeing too much flow out in the cortex, just primary flow in the central, medulla of the kidney. But the left kidney now there's the kind of the outline of the board of it. It's very echogenic. It's definitely diminished in size. I don't know what they're doing with their color box there. Either way, get your color box over the whole kidney. But again, there's no flow at all, within that kidney right now. So it makes sense, there's no arterial blood flow getting in.
Right.
There's no venous flow coming out because nothing's coming in. So no blood flow in, no blood flow out. So essentially, unfortunately, that's a dead kidney. Dead kidney.
Oh my God.
Dead kidney. Well, the beautiful thing about kidneys is, they'll compensate. If this guy's no bueno, this guy's gonna get big and try and take over. And it's gonna hypertrophy, yep. Renal artery stents. So renal artery stenosis, again, is typically caused by atherosclerotic buildup within the proximal portion of that main renal artery. So we can go in there with percutaneous transluminal angioplasty. We can do our balloon angioplasty, open up the vessel, place a stent now to keep that vessel open. So you can place nice medicated stent in there. And that patient's going to have, significant, tremendous improvement of the renal function now. So this will help to improve or stabilize the patient's blood pressure, preserve the renal function, and prevent development of end-stage renal failure. So again, our goal is to prevent them from going into that end-stage renal failure where they're going to require dialysis. That percutaneous stenting has become a standard treatment with high technical success and low mortality rate. There are long-term complications, with in-stent restenosis, so the same issues, that cause the initial stenosis can cause restenosis of that stent. But, thankfully, due to stents both being medicated and atherosclerosis, being a slow process, they tend to live pretty, healthy, good lives after that, after being stented and reperfused. Ultrasound is used as a follow-up, to assess the success of that intervention, determine the baseline of the peak systolic velocities after stent placement, and then, follow and monitor stent patency, and then potentially identify any long-term, complications. So the exam, when they do have a stent, is, very similar to if we're just assessing the native vessels. There's just slight differences in terms of the velocity measurements. So evaluate the abdominal aorta, for any evidence of significant atherosclerotic plaque, stenosis, aneurysm. Same that we do in in our normal patients. Obtain those pieces stock velocities again for our calculation. We follow the renal stent placement, evaluating the stent in its entirety, and evaluating the renal artery, all the way from the organs to the hilum. So utilizing our same three functions: grayscale, color, Doppler. Obtain our peak systolic velocity measurements from within the stent and from the renal artery origin, proximal, mid, distal, all the way out. And we can include the intrarenals. So essentially the protocol is exactly the same. We're just paying closer attention to the stent and measuring velocities, through that stent. Our standard limitations, still hold true: bowel gas, body habitus, patient respiration. Again, arrhythmias. If patients have irregular heartbeats, those arrhythmias cause fluctuations in our peak systolic velocities. So with arrhythmias, typically we have one that's high, and then one that's low, significantly lower than a waveform that's kind of in the middle. So pick that one that's in the middle. So the criteria now, so the velocities, we're allowed to go a little bit higher when the patient has a stent. The stents are kind of inherently a little bit stenotic. So the velocity criteria is just a little bit higher. And because that velocity criteria is a little bit higher, the ratio now can be a little bit lower. So we can have a larger denominator, which lowers that ratio down a little bit. I'm sorry, a higher numerator, which lowers the ratio down a little bit. Um, Aneurysms. So since it's an artery, they are susceptible to potential aneurysms. So aneurysms could be saccular or fusiform. So we know our true aneurysms, we get dilatation of all three vessel walls and can present same like an aortic aneurysm, either saccular or fusiform on the main renal artery itself or potentially one of its branches. Renal artery aneurysms are very, very rare. If they do occur, they tend to be near that bifurcation. Some patients could have congenital, malformations that cause an aneurysm, inflammatory issues. There could be trauma, so it could be, status post maybe an kidney biopsy or arterial puncture. Atherosclerosis, again, weakens the integrity of the vessel walls, could lead to them becoming aneurysmal, as well as fibromuscular dysplasia. So when we get those areas of narrowing, those stenotic lesions, and then the dilatation after it, could lead to that vessel becoming aneurysmal. Signs and symptoms of a renal artery aneurysm: maybe there's a palpable mass, high blood pressure, hypertension, blood in the urine, flank pain. And then with any aneurysm, we worry about the potential of rupture, being the main complication. We could see it as an anechoic mass on grayscale, and when we put our color on, it would fill with color. So normal main renal artery diameter is about half a centimeter. So 5 millimeters, about half a centimeter. If we see a renal artery that's greater than 2 centimeters, this requires immediate surgical intervention. So that's huge. If you think about it, what your aorta is around that. So if you're seeing a renal artery around the size of your aorta, it's noticeable. It's going to be an issue.
It's weird they say palpable mass then. Cause like, how big would it have to be for it to be a palpable mass?
Okay.
Right?
Not the people we're scanning. Again, some of the extrarenal causes, if the aneurysm is outside of the kidney and the main renal artery, atherosclerosis, FMD. If that aneurysm is within one of the intrarenal vessels, could be due to, some genetic conditions, some of the arteritises, vasculitises. Which are showing that, a focal saccular aneurysm off that main renal artery. This is right in the hilum. Oh. A large pseudoaneurysm could potentially be present. So in this, again, same with any pseudoaneurysm. We see that large, vascular mass with the yin yang flow pattern within it. All right, some non-vascular causes or non-vascular renal diseases. And how they can, impact our Doppler waveforms. So renal parenchymal flow resistance may also increase in patients besides renal artery stenosis. So that meaning we can have increased resistive indices, and issues with our arterial flow when patients have things like urinary tract obstructions. So anyone who potentially might have a kidney stone, that's obstructing the flow of urine, and leading to hydronephrosis. They can have acute or chronic parenchymal disease or tissue disease of the kidney. That acute or chronic parenchymal disease could be a result of renal vein obstruction, glomerular sclerosis, acute tubular necrosis is we'll see particularly prevalent in transplant patients where the kidney's basically breaking down from the inside. Pyelonephritis, which is infection, pus getting into the ureter and then working its way into the kidneys, infecting the kidneys. As a result, these conditions all will increase resistance within the kidney, leading to more pulsatility, increase RIs. With renal vein thrombosis now, this is impedance to venous flow that can be caused by intrinsic obstruction. So again, those are those terms when we're talking about clots within the venous system are intrinsic obstruction or extrinsic compression of the renal vein. So something within the renal vein blocking the drainage, or something outside compressing on the renal vein that then is preventing drainage. Risk factors for renal vein thrombosis, including pre-existing kidney disease, patients who are in that hypercoagulable state. So, cancer patients, pregnant women, status post surgery, patients who have factor V Leiden, sickle cell disease, are all potential candidates. Patients who have vena cava or ovarian thrombosis, ovarian vein thrombosis. So if they've had a massive DVT, that massive lower extremity DVT is propagated all the way into the the IVC. It's working its way up the IVC. It could potentially be blocking the renal veins at that point, and that thrombus could then work its way into the renal veins or obstruct the flow in the renal veins, leading to nephrotic syndrome. Trauma and dehydration are potential causes. And then masses or tumors, putting pressure on the renal veins from the outside. extrinsic compression could also be Cracker syndrome. Let's see that listed there as well, but again, that's some of that extrinsic compression, enlarged lymph nodes, any sort of masses, tumors. With renal vein thrombosis, it's an acute onset. These patients will have pain, blood in the urine, protein in the urine, elevated proteinuria. They could also potentially have leg swelling. It could result in pulmonary embolism. Like we'd expect to see, in the patient's got a DVT in the legs, we expect leg swelling. So same thing's gonna happen to the kidneys. The kidneys are gonna swell, they're gonna become enlarged. The parenchyma becomes altered, so it becomes, enlarged, it looks very spongy. It becomes more hypoechoic, so it becomes a little bit darker. So direct identification of the thrombus, may be hypoechoic. As that thrombus becomes more, fibrotic, it can start to become, brighter or echogenic, but in that acute stage, the kidney becomes large. It looks like very spongy in appearance, becomes more hypoechoic, a little bit darker. We might see absent Doppler flow signals in the main renal vein, or a very slow trickle of flow without basicity in the renal vein. Large collaterals may develop that show some of that sluggish Raylos formation. Typically, this induces ischemic parenchymal damage and acute renal failure. So as it progresses and becomes chronic now, sometimes the patients might be asymptomatic, or they could have, nephrotic syndrome. So if they've done permanent damage to the kidney, they'll have blood in their urine. The renal vein, like any other vein that we've had a clot in, can become recanalized. So we can wind up with fibrotic scarring that we'd see, in the vessels of the legs. We can have this, so we're all affecting the kidneys. There could be collateral development that occurs. And then in the chronic stage, for renal vein thrombosis, now the kidney now is diminished in size because damage has been done to it. It becomes scarred, it becomes fibrotic from the clots that were once in the kidney. And then the echogenicity of it now has become increased. So acute, it's enlarged, hypoechoic. Chronic, it's diminished in size and increased in echogenicity. Venous flow may be present throughout the renal. So venous flow may be present even though the renal vein is occluded. So you can just kind of keep that in mind. The occlusion might be more distal, we're still seeing some flow in it. Or it just may be very sluggish and difficult to detect. So this is an example of an acute, renal vein thrombosis. The kidney is very enlarged. It's kind of got this more spongy appearance to it. It's hypoechoic now, so it's darker, a little bit darker than we expect to see. We've lost that, real clear definition between our bright echogenic medulla and then the hypoechoic or darker cortex. So we lose that chordo medullary, borders. So in this case, this is a patient who has renal cell carcinoma. So we know that particular type of cancer is, predisposes them to developing clot, thrombosis. So in this case now, they're imaging the renal vein there. Got renal artery, the renal vein anterior to the artery, and then thrombosis or thrombus within that main renal artery there. So it's a partially occlusive now, main renal vein. So a little further out, again, you can see the intraluminal echoes within it. And then thrombus now in the patient's IVC. So it's worked its all the way into the IVC now. That was a nice picture, again. Patient, looks like they're suffering from nutcracker syndrome, so we're transverse now. Got aorta, SMA, that left renal vein being sandwiched between the two. So it's very, very thin through there. Then we get the dilatation. So again, there's probably stasis of blood that happened right there because of that nutcracker syndrome. Clot developed. So there's still some blood flow getting around it, so it's partially occlusive. Color, we can see the blood flow getting around that central thrombus there, getting through that little stenotic area, trying to make its way into the IVC. Something that when we get into doing and talking about the transplants in the next lecture with renal vein thrombosis, it can cause RIs to become so high that during the diastolic phase, we actually get a flow reversal. So again, kidney's not draining now, so we have obstruction of the drainage. Blood flow is still able to get into the kidney, so the kidney, again, it's becoming enlarged, pressure's building up in that kidney because it's so swollen, so enlarged. So systole, it's enough force to push blood flow into it. But during diastole, when it relaxes, the pressure's so high in that kidney, it's pushing the blood flow back out. So renal vein thrombosis can lead to this bidirectional flow. So that's something that's kind of unique to renal vein thrombosis, unique to one other type of rejection. We'll get into that, but it could also, indicate renal vein thrombosis when we see that bidirectional flow in the renal artery. So neoplastic obstruction, again, it's another thing we worry about with renal cell carcinoma. It's commonly associated with renal cell carcinoma. There's tumor extension into our vessels. So there are other potential tumors that we might encounter. So renal lymphoma, transitional cell carcinoma, and Wilms tumor. Vena cava invasion is more common on the right side. Why do you think that is? Shorter. It's got less distance to travel. Just makes sense, yeah. So it's got the left, right renal vein is just much shorter in length than the left. The SMA blocks it. No, I'm just kidding. Good old Nutcracker is actually doing something good for you there. Yeah, it's just shorter in length. It's got less distance to travel, so it's more common to have that tumor invade on the right side. Contrast, CT is preferred diagnosis for this. So a tumor containing renal vein is almost always just going to be distended. Doppler signals may be present, around the tumor. So we get to put our color on, see if we can get arterial flow signals or arterial signals in that mass or tumor itself. You see a hypoechoic mass that invades the renal vein. That could eventually work its way into the IVC. Oncocytoma. So this grayscale image just demonstrates a well-defined, uniform, epigenic solid mass, the right kidney. So this had a distinctive flow pattern. So they refer to it like a spoken wheel or ring of fire pattern seen within this mass. So the vascularity was surrounding the periphery of it. So it's just another renal mass to kind of just familiarize yourself with. Dissection could also potentially occur. So we could see, potential renal artery dissection. So you can imagine this would be very, very hard to try and diagnose with ultrasounds. CT, much better confirming that diagnosis. But with any dissection, we would look for, the presence of a true lumen and a false lumen, an echogenic intimal flap. particularly transverse, kind of cutting across the vessel. AVM and ABS. So this is something that might be a little more common, particularly if they've done any sort of renal biopsy on this patient. So an AVM is a congenital malformation, so arteriovenous malformation. So this is a fistula that a patient is born with. They're very uncommon. Two types. There's a sarcoid, which is more common. So AVM has a dilated corkscrew appearance. And then cavernous arteriovenous malformations that have a single dilated vessels. So with these, regardless whether it's a congenital or accidental arteriovenous fistula, when we put our color on the kidney, or you'll take a picture of the kidney, you'll see areas that are anechoic that represent that blood flow. You put your color on, it just lights up with color over that area. With any fistula, it's gonna be fast, turbulent flow. So the arterial signals are gonna be markedly elevated, very turbulent. Any venous signals are gonna be now mixed, pulsatile venous signals with elevated velocities. So you'll see a visible color blurring when you put your color on. The ones that are required, most common cause again is going to be a result of that renal biopsy. So for kidneys, in order to make that diagnosis of renal failure, they have to biopsy the kidney and assess the kidney cells to determine, are they in what stage of renal disease they're in, and to kind of categorize them. So they have to perform that biopsy. Again, that could be a result of that renal biopsy. They go in with the needle, puncture the artery, puncture the vein, and create that fissional connection. Trauma to the kidney, penetrating procedures and malignancies can also potentially cause a fistula to develop as well. It's a little bit harder to see, but we got our kidney here. We see this echogenic areas. Now within the kidney, we put our color on, it just lights up with color. So, that's not cysts. They're not, it's not hydronephrosis. We put our color on, it's going to fill up with color like that. As soon as you see that, you've got either an AVM or a fistula going on. Power Doppler, again, they just kind of put the color on those areas. They light up with color. Then our velocities are going to be, very, very fast within the intrarenals. It's almost 300 centimeters per second, so 295 or 2.95. Arteries can suffer from vasculitis, or vessels. We can potentially have inflammation of the vessel walls. So patients who suffer from glomerulonephritis or Wegener's granulomatosis. So regardless of the cause, if we have vasculitis, just recognize that with those thickened walls, it leads to restricted blood flow. So we have inflammation of the walls. The opening or the lumen of that vessel will become narrowed. That's going to reduce the blood flow, lead to stenosis that can potentially result in tissue damage. Those patients will probably have blood in their urine, hematuria, protein in their urine, result in kidney failure. Patients might present with flu-like symptoms, fever, body aches, muscle cramps, reduced appetite, weight loss, discolored urine. That's it. It's freezing.
Yeah, it's so cold.
Yeah. Absolutely treacherous. You're right.
You're right, it is. Like it's set to 74, but it's reading to 73.
Definitely not 73 degrees.
Feels good.
Not like that day in Larry's class.
That's I can feel my feet.
It's so cold.
It's freezing.
Poor woman.
I was freezing, I know.
Hasn't even started yet, winter.
I thought, yeah.
I think it's just because
Yeah.
it's like, I wasn't using because I
I
told
think you're
everyone.
probably sitting in this too much, not like.
Turn on the
Yeah.
Studies.
But it's not
probably.
hot enough to have the
Yeah,
air on, so
yeah.
you have this weird little limbo, you can't do anything.
That's.
Blankets.
That's what Vera told me at breast center, she said, are you cold? I